Good afternoon. My name is Professor Richard Harding, and I'm absolutely delighted to welcome you all to the 2020 Cicely Saunders International Annual Lecture. It's my pleasure to have you all with us today, and my first role is to introduce our colleagues from the 6 remote sites that we have joining us this afternoon. So the first site that I would like to welcome is Belfast. Are you there with us, Belfast?
We're very glad to be here in this very strange time. Thank you very much. And we're really looking forward to the lecture. So we're sitting in Northern Ireland Hospice in Belfast.
And the next site that I would like to invite to say hello is Preston.
Hi, good afternoon. I'm Andrew Fletcher. I'm the Medical Director here in St Catherine's in Preston, and we're really pleased to be joining you again this year. So thank you.
And the next site I would like to invite to say hello is Cork in Ireland.
Hello from Cork in Marymount University Hospital. We'd like to congratulate Cicely Saunders Institute on your 10-year anniversary, and we'd like to join you with our own celebration of 150 years of the provision of palliative care from Marymount University Hospice here in Cork to the people of Cork and beyond. So we're delighted to plan for the next 150 years, and so very interested to hear about these lectures to guide us on that path.
And the next site I'd like to introduce is Reggio Emilia in Italy.
Good morning, everybody. This is Massimo Costantini. I am the Scientific Director of the Research Institute of Reggio Emilia and Head of the Palliative Care Unit. I'm very happy to join this meeting and to be with you. Thank you very much for this interesting opportunity.
And now I'd like to move over to Dublin to invite our colleagues in Dublin.
Hi, my name's Karen Charnley. I'm the Director of the All Ireland Institute of Hospice and Palliative Care. I'm delighted to be part of the lecture again this year.
And now it's my enormous honour to hand to Professor Ed Byrne, who is the Principal of King's College London and will give the opening remarks. Thank you, Professor Byrne.
Thank you very much, Professor Richard Harding. If I could start with a personal note, I'm coming to the end of my 7-year term as the President of King's, and one of the huge pleasures I've had is to serve on the advisory board of the Cicely Saunders Institute and to chair this annual lecture, and of course to work with Irene Higginson and her wonderful team. So this year is the 10th Cicely Saunders International Lecture. Clearly, as mentioned, it's somewhat different this year as it has been run entirely online. However, on an upside, this has given the opportunity to let more people attend. And we estimate that almost 1,000 people are joining us from across the globe. So welcome to you all. The last year has been an extremely busy year for the Cicely Saunders Institute teams, and indeed for all people in palliative care. There have been many existing patients and families needing care and support, and existing programs of research and teaching, all of which have continued to progress. And the Institute teams have launched new clinical support and research and education, responding directly to the hard challenges of COVID-19 faced by many patients and families. I'm delighted to highlight that the Institute's innovative Master of Science program in palliative care achieved 100% overall satisfaction for a 2nd year running in the national assessment, an outstanding achievement. The team have kept the MSc program running successfully, offering blended learning and remote teaching during lockdowns, keeping course participants safe and enabling them to take part from across the globe. So thank you to all the staff and students who have worked so hard to make that possible. In addition, the PhD program and the medical student teaching of the Institute have been continuing with learning adapted to the new restrictions. I'm really pleased to launch at this lecture the Cicely Saunders Institute Triennial Report, which highlights many of the achievements of the Institute. The links are available from the team's website and in the announcement for the lecture. So now, if I could just say a little about our outstanding 3 speakers. Each of these speakers could be introduced in such a way that it would take the time for the whole lecture, so we have abbreviated the introduction. Professor Steve Pantilat is the inaugural chief of the Division of Palliative Medicine and the Kates-Burnard and Hellman Distinguished Professor in Palliative Care at UCSF. He is an internationally recognized expert in palliative care, having published over 100 peer-reviewed papers, many book chapters and textbooks in addition. He is the director of the Palliative Care Quality Network, a collaboration of 130 palliative care teams. Dr. Pantilat also works to engage and educate the public about the benefits of palliative care and is the author of Life After the Diagnosis, Expert Advice on Living Well with Serious Illnesses for Patients and Their Caregivers, published by DaCapo Lifelong Books. Professor Pantilat and his team have regularly joined us remotely in recent years at our annual lecture. Our second speaker, Dr. Eve Namasango, is from the African Palliative Care Association, where she is Programs and Research Manager. She is also Honorary Health Scientist at the College of Medicine at Makerere University. Dr. Namasango is a King's alumnus, having graduated with an MSc, then a PhD in Palliative Care from the Cicely Saunders Institute here at King's. She now coordinates the 180-member African Palliative Care Research Network, which aims to build capacity and research and knowledge translation across Africa. She has over 15 years' experience in global health research and is a co-investigator on the COVID-19 pandemic rapid evidence synthesis group for Uganda, COVPRESS. Eve is a panelist on the African Global Health Security COVID-19 initiative, which is setting priorities for enhancing good mental health in Africa in the current era, and a member of the Evidence Consortium on Women's Groups in Africa. So last but not least is somebody who scarcely needs an introduction, someone of the greatest eminence in her field, Professor Irene Higginson, Director of the Cicely Saunders Institute and Professor of Palliative Care and Policy here at King's. I should say as well, as a massive contributions to a discipline, Irene Higginson has been a huge contributor to this university. She is an NIHR Senior Investigator Emeritus and a Fellow of the Academy of Medical Sciences, both awarded for a contribution to the field. She is well known for her research extending palliative care beyond cancer in outcomes measurement, breathlessness and home care, incredibly important in the COVID pandemic. She has been leading several initiatives, including a multinational study called COVPAL, to try to improve the palliative care for people severely affected by COVID-19. So I'm really looking forward to this lecture, and I'll now pass back to Professor Richard Harding. Richard.
Thank you, Principal. So as you draw to the end of your tenure of leadership at King's, we'd also like to really thank you and acknowledge you for your contribution to the growth of palliative care and your personal commitment to the Institute, so thank you. So our first speaker I would like to bring to talk is Professor Steve Pantilat, who you've now heard is going to be joining us from UCSF in California. Steve, we're absolutely delighted to have you open this year's annual lecture. Thank you.
I'm delighted to be here. Thank you so much. The COVID-19 pandemic has created an unprecedented tragedy around the world. And in the United States, it's been accompanied by political unrest, increased evidence of systemic racism made worse by the pandemic, and has created incredible crisis both in our healthcare system and in our society, and has demonstrated the incredible need for palliative care for people with COVID-19, and has brought palliative care in many ways to the forefront in the care of patients generally and in the care of people with COVID-19. Rahm Emanuel, who was a mayor of Chicago and was chief of staff to Barack Obama, famously said, "Never let a good crisis go to waste." And while we wouldn't wish this crisis of a pandemic on anyone, it did create an opportunity to provide palliative care in a way that we hadn't done before. And I'm really proud of the way our team really embraced this opportunity to see how we might expand and extend our care to patients who really do need it. And so I'm going to share with you today how we use telemedicine to support palliative care during the COVID-19 pandemic. So I want to just share with you my team. This is the Division of Palliative Medicine at UCSF. This really was a team effort, a very broad-based effort to work on these issues, to bring palliative care to patients in the setting of a pandemic and to use telemedicine to do that. I want to focus on these 5 areas quickly, give you a 30,000-foot overview of how we use telemedicine to promote palliative care in the outpatient setting, the inpatient setting, how we used it remotely to help patients far beyond our institution, talk a little bit about the impact of the pandemic on our team and how we've been using telemedicine for our team, and then a few words about policy and how policy can really promote the use of telemedicine. Let me start with outpatient telemedicine. Before the pandemic, our outpatient palliative care services, half our visits, 50%, were by telemedicine even before the pandemic. We were the highest users of telemedicine at UCSF, both in absolute numbers and by percent. And within about a week of shelter in place here in San Francisco, we went to 100% telemedicine, really a remarkable switch that happened very quickly with people working from home, using telemedicine to care for our patients. We found that our patients wanted to continue to see us. They were anxious and worried about what would happen. Obviously, the images of people in ICUs and talks about the shortness of breath and many people dying left many of our patients with serious illness incredibly anxious and worried, and they wanted to continue to connect, and our volumes remained very high throughout the pandemic. The advantages, we could include family even before the pandemic, but certainly during the pandemic, we could include family from around the country and around the area, around the world, who wanted to participate in these visits in a way, even if they couldn't make it to UCSF, and that's been a huge advantage. It turned out it was less stressful for our patients, which is to say that they didn't have to leave their home, they didn't have to get dressed, they didn't have to figure out how to carry their portable oxygen or get their wheelchair into the car, drive into San Francisco Park, all the stresses of coming to a visit at the institution, and so it made it much easier for them. In fact, some patients, we see them, in bed in their pajamas, and so it worked very well for them. It turned out it was safer in the setting of the pandemic, not having to come to the hospital, to the clinic, and then finally, they don't have to use masks when they're at home. The few times that we've been in clinic with patients, the use of masks by our team and by the patients and families means that you lose a certain type of communication by not being able to see someone's mouth. And on video, you see their faces very clearly. We don't have to use masks. And then finally, this was in research we had done even before the pandemic. Brooke Calton and Cara Bischoff led a team that surveyed patients and families in the outpatient setting who had used both inpatient and telemedicine palliative care and found incredibly high satisfaction for patients and families with telemedicine. They would highly recommend it to others. And so that made us confident that pursuing this for our patients in this setting would be acceptable, not only acceptable, but produce a lot of satisfaction, and that's been true. We found, as I said, that a lot of our patients were very anxious, very worried about the pandemic, worried about what would happen if they got COVID-19. I think one of the big stories early in the pandemic, which is still there, had to do with restricted visitation in the hospital. Initially, there were very few visitors at all, really only in the end of life setting, and many patients were worried that if they came to the hospital, they would be separated from their families, and if they faced the end of life, would also be separated. And that played an important role in decision making for patients. And we found that we needed to go back and talk to our patients about their goals of care. And I just wanted to share with you, this is my patient, Bob Lewis, with his grandchild. This was an article that appeared in the San Francisco Chronicle. Bob has lung disease, and we really had to think carefully with him and his family about what would happen if he got COVID-19. Would he even want to come and get tested? He decided he did not want to come to the hospital under any circumstance. And so we talked about what was the plan B for if he got sick, how we would take care of his shortness of breath acutely at home. And this was common for many of our patients who faced similar crises. So that was the outpatient side. That just ramped up. On the inpatient side, I will say that before the pandemic, we did zero telemedicine at all. It just was not an issue for us. We just went and saw patients in their rooms. But quickly after the pandemic hit, we realized that there were challenges in going into patients' rooms, and there were challenges because of restricted visitation. And so the question was, how could we serve our patients, both the clinical team, our palliative care team with patients, and also patients with families? One of our couple of our local foundations reached out to us very early on and said, well, how can we help you? And I have to give credit to our team, who were really smart and said, you know, what we need really are iPads to communicate with patients. And so here they are. We had a donation of 12 iPads from one of our local foundations, the Stupsky Foundation, iPads and stands, and we started using these to communicate. And now they're actually available throughout the institution. And I would say that now we're at about 50% of patient contacts include some amount of telemedicine, either to bring in family members or to bring in clinicians in some type of setting. For example, even in a family meeting where we might have a small conference room and there might be 5 family members and 5 clinicians and the patient involved in a family meeting, that will exceed the safe number of people who can be in a small room. And so even within the hospital, we may have clinicians who telemedicine into a family meeting to keep everyone safe. What we've learned is that it allows us to preserve PPE. This was a real issue early in the pandemic and still a concern. It protects the team from being exposed unnecessarily to patients with COVID-19. Obviously, if we have to see them, if there's something that's required, we can do that, but very often we can do the work without it and protect the team. In palliative care, we have a small team, and so one person getting sick and the rest of us being in quarantine would really limit our ability to provide care, and so protecting the team turned out to be very important. It connects patients and families. I think this has been one of the real bonuses and one of the great insights that we've had as a team, is just how important it is for patients to be connected with their family members, even for patients in the ICU who are not responsive. We found that having the iPad there focused on the patient allowed family members literally from around the world to be present at the patient's bedside. We had one patient who had literally family around the world, 13 different screens on the Zoom, being with him, praying, singing together, and visiting with each other and with the patient. So it's been a really important way to create that connection. We've also implemented a system of proactive consultation for patients with COVID-19 in the intensive care unit. And while this isn't directly a telemedicine advance and innovation, the telemedicine does make that possible at various sites, even where we may not have our team, for example, at our Mount Zion campus, where we opened a new unit to take care of people with COVID-19. But this process of proactive consultation for people with COVID-19 in the ICU is something we've been talking about for a long time, to proactively consult in the ICU. And here was this other opportunity that suddenly made this possible. And identifying this opportunity and taking advantage of it was another great insight by the team. And the dominant experience that we've had is, why didn't we do this before? Now that we're doing it, it seems so obvious and so beneficial for patients and their families that that's really been the question. I want to share just another way that we used telemedicine, which was remotely, recognizing that the epidemic was very uneven. So there were places like in the US, like New York City, where it was devastating. I'm sure many people saw those pictures, like there were in Italy and Spain and other parts of the world, really a devastating pandemic. While at UCSF, we were very fortunate and had not experienced a surge at all. And so we had a UCSF to New York Presbyterian transfer of expertise, and we used telemedicine to provide palliative care, largely goals of care conversations to patients and families at New York Presbyterian Hospital. And within about a week or so, through incredible work by Mike Rabo and Eric Guadera and Alex Smith and Michelle Murad here at UCSF, we're able to get people credentialed at New York Presbyterian, and we're able to begin these remote telemedicine palliative care. A lot of it was by telephone, more than by telemedicine, by video. And by telemedicine, I just want to be clear, what I'm talking about here is video contact between patients and clinicians, although often it does default to telephone when you can't make the connection. As I said, largely goals of care conversations. This was a lovely ad in the San Francisco Chronicle from New York Presbyterian to UCSF. I will give UCSF a lot of credit. It was a completely volunteer effort, both on the part of clinicians and on the part of the institution, to really step up and help out our colleagues. Danny Shamus, one of our palliative medicine physicians, wrote about this experience and what it was like providing palliative care by telephone and by video, and wrote that we can touch with words, that we can hold with silence, that we can speak with breath, that we can see through sounds. Really demonstrating, and I think so poignantly highlighting how it's possible for us to have meaningful and important and intimate contact with patients and families, even when we're not in the same room as them, even when we can't touch them with our hands, and even sometimes when we can't see them. I do want to highlight a few things about telemedicine policy that made it possible. In the United States, physicians, nurse practitioners, PAs are licensed by the state, and so typically care has to be provided in the state. So I can do telemedicine to patients anywhere in California, but not if they go to Nevada. Well, during this time, those policies were relieved, which really allowed us to provide care, for example, in New York and other places around the country, to really even the supply of palliative care to where the demand was. Reimbursement is another important issue, certainly in the US healthcare system. That which gets reimbursed gets done. Our Center for Medicaid and Medicare and Medicaid Services had very restrictive policies around reimbursing for telemedicine. Those restrictions were eased in the face of the pandemic, which really made it possible to implement telemedicine. And so thinking about issues around reimbursement, as I said, the interstate visits, defaulting to telephone when you can't get the video to work, although I will say our experience is that probably 98% of the time we are able to get it to work. One of my colleagues, Cara Bischoff, was sharing a story of a patient who lives 3.5 hours away from UCSF and drives about 20 minutes to a neighbor's house who has good internet access and a smart device where she can actually do the telemedicine. And that drive obviously is much easier for her than driving the 3.5 hours to UCSF. License and credentialing that I talked about, making those things rapid and easy, made it very possible for us to do this work. Lastly, I just want to highlight the use of telemedicine for the palliative care team. And while we have found that the use of telemedicine for patient care has been an overall extremely positive innovation for us and for our patients, and really helped us to bring palliative care to patients who might not have otherwise been able to access it, it's been very difficult for the team. The isolation and the distance from each other has been very hard. In the outpatient setting, we all primarily do our work now from home. And so where the team would often be in the office together, seeing patients together, we are now isolated from each other. And so there have been real challenges around it. And so telemedicine has allowed us to combat isolation by having our team meetings by Zoom. It has increased connection in many ways, particularly for a team like ours that's distributed across different settings and different sites around San Francisco. It has allowed us to be connected to each other and to have smaller teams that meet frequently. We often will break out into small breakout rooms to have really much more intimate connections, one-on-one or 3 at a time, rather than a big screen of people. It also has leveled participation. We have found that at our main campus, people would come to the conference room together, and there was great connection there. But the folks who were on the big screen by Zoom often felt much less connected and less a part of what was going on. And while Zoom has its challenges, it does in fact allow people to have a level participation. Here you'll see one of our Zoom meetings, in fact, of the division. We get to see babies, even we see dogs. It's really, in many ways, created a different kind of connection and warmth. It has allowed us in the United States also to address social justice issues, as if the pandemic wasn't enough and our political discourse wasn't bad enough. Issues of social justice, systemic racism really came to the forefront during the pandemic, both those systemic injustices that were highlighted by the pandemic and where we saw disparities really come out in the way in who got COVID-19 and who died of COVID-19 and the systemic racism problems that were reflected in healthcare, but also the issues, the murder of George Floyd and many other situations. And it allowed us really to address that issue as well in a meaningful way, something that was felt very deeply and strongly by our team. And so there've been a lot of advantages to using this system. I will say that there is Zoom fatigue, and so we've now learned to limit how much time we spend on Zoom because it can be very exhausting to spend the day on Zoom. And then I just want to wrap up by saying sort of what's different and what's the same. There's no eye contact when you're on Zoom. So when you see a patient, you can't actually look them in the eye. And that's been very hard, but you don't have to use a mask. And so there's a lot of intimacy and a lot of connection that you can do and a lot of nonverbal communication that you can get nonetheless. And while there is no physical touch, as Danny wrote so poignantly, you can touch the heart by video in a very meaningful way. While some patients will have limited access and comfort with telemedicine, the use of outreach and navigators by our team, I will say our nurse, Eve Cohen, and our clinic navigators, and in the hospital using telemedicine navigators in the ICU to set up the telemedicine has been really important. So these are new roles, new jobs, and if we attend to this carefully, we can almost always get the telemedicine to work, assuming that the patient does in fact have some sort of internet access. And then we went from this place of really just, can you try it, see what it's like, to really embracing this and deciding that we needed to study and master it, both in understanding what is lost in telemedicine and how do we overcome it? When are the times when telemedicine isn't right for patients and families? And then how do we master it? And ultimately, how do we teach it? And we have important projects, Brooke Calton and others, looking at how we teach telemedicine to our students. And I'll just go back to what I said earlier. Why didn't we do this sooner seems to be the dominant experience here. As we continue to use telemedicine. And I just want to once again thank the team in the Division of Palliative Medicine, really an extraordinary effort to continue to bring palliative care and to extend palliative care to the people who need it during this incredibly trying time of pandemic. And it's really a delight to be able to participate, and I'll just highlight that telemedicine has made my participation today in this annual lecture just so much easier, and it's wonderful to have so many people participating. So thank you, Irene. Thank you, Richard. Thank you, Principal. It's really been a delight.
It's my enormous pleasure now to introduce Dr. Eve Namisango from Kampala. As the principal said, Eve has been both master's student and PhD student, and now is an academic colleague of ours on a number of funded studies in our global health program. Eve, over to you. Thank you so much.
Thank you, Richard, for the very kind introduction. Greetings to everybody who is listening in. And my presentation is about the impact of COVID-19 on palliative care in Africa. I'll talk through the challenges, opportunities, and emerging innovations. And just to set the context, Africa is home to over 1 billion people, and 60% of our population is below the age of 25 years. So you can imagine the impact of preventive measures such as the closure of schools on teenage pregnancy and violence against children, some being married off and may never resume school again. And then in terms of diversity, most of the countries are low income, and then 18 of the countries are classified as conflict or fragile, and that has significant impact on neighboring countries which are hosting high volumes of refugees. And we know that accommodation is crowded in there, and there is very limited access to safe water, access to quality health care, as well as sanitation. And we also have a very high burden of underlying disease, ranging from HIV, tuberculosis, and cancer. And any interruption in access to health care has a huge impact on disease mobility in the region. And credit for this caption goes to ASSET. Since the first COVID-19 case was confirmed in sub-Saharan Africa, the cumulative number of confirmed cases has been increasing in the region, and Southern Africa bears the highest burden of the disease. And this is feedback from the World Health Organization when it assessed preparedness of African countries for COVID-19. And where we see the green shades are countries which felt that they were adequately prepared for the pandemic. And we are just waking up now to say that actually we are not prepared, because if most of our patients report late and some present with moderate to severe COVID-19 and may therefore require hospitalization. And we have about 2.5 beds for 100,000 population, and we have about 1 ICU bed per million population. So if our patients present late and need hospitalization, definitely this infrastructure cannot support their care. And not forgetting that most of these services are concentrated in urban centers and none are available in rural areas where over 80% of our population resides. And in terms of preparedness for palliative care service providers, this is a survey which was led by SABA, and 21 countries participated. And we found that access to running water, soap, and disinfectant products was a big challenge for palliative care healthcare providers, and staff were concerned about their own security. And most importantly, 41% did not have appropriate personal protective gear. And then staff were battling high levels of worry and anxiety, and only about half reported having palliative care protocols for symptom management and psychological support. And this is another rapid review led by Aladayo, and I'm also a co-author on this. And our question was, do clinical management guidelines for COVID-19 in African countries reflect the African quality palliative care standards? And we used a rapid review methodology, and we identified 5 Ministry of Health approved COVID-19 management guidelines from 15 countries. And the guidelines scored quite well, or very well, on standard 2.5. That was the management of opportunistic infections. And other standards were just partially met. Examples of such include planning and coordinating care, access to specialist palliative care, pain and symptom management, to mention but a few. But most importantly, is the following standards were not met at all. Ethical care, which is aligned to human rights and avails legal support, managing grief, loss, and bereavement, providing culturally sensitive care, as well as addressing spiritual care needs of patients. Very few guidelines met those standards. So I'll briefly talk about how African governments responded to COVID-19. We had lockdowns, banning of private transport, restricting meetings of more than 5 people, night curfews, military deployment in communities, which resulted into regressing of democracy and exacerbated the violation of human rights. And right now, public transport is open and our patients can move, but because of the public health preventive measures, they are required, transporters are required to carry a smaller number of passengers at a given time, which has resulted into an increase in out-of-pocket costs for transport, and therefore patients may not be able to travel to healthcare facilities to access the care. And COVID-19 has grossly destabilized health services in Africa. I'll start with the impact on HIV services. Access to antiretroviral therapy has been impacted on from the supply chain level to actual access by patients. Then our access to community level antiretroviral therapy is also affected because of the ban on community level meetings. People who have been exposed to HIV find it difficult to access the pre-exposure prophylaxis. And then our youth and adolescents can no longer interact in safe spaces to talk about issues of adherence and other challenges in life. And also our healthcare workers are dying, and many of them are battling severe anxiety, worry, and other mental health concerns. And WHO conducted a survey that assessed the impact of COVID-19 on access to health services, and response from 122 ministries showed that 47% reported an impact on access to palliative care services. Cancer care was also negatively impacted, rehabilitation, and also the access to cardiovascular disease care. And all these are likely to lead to increases in mortality. And also the access to cancer care has been negatively impacted. For example, there is a suspension of screening and outreach services. Sensitization campaigns are halted, and all these threaten our strategy of early detection and enrollment into care, which improves survival of patients. And we've had a negative impact of COVID-19 on minority groups in Africa, and these include LGBTs and sex workers. These people have been bundled up and detained. Their hubs have been dismantled by the new preventive measures, so they can no longer access care from their previous hotspots, and now they are going underground. And we will recall that HIV is highest in these minority groups. So if they are not accessing treatment, their outcomes will be poorer, and then they will also keep on spreading HIV to the general population. And we are glad about the response from the human rights bodies. So there is more awareness about the need to provide quality care to these populations. And also COVID-19 has negatively impacted on our grief and bereavement norms. We are increasingly seeing COVID response teams taking over body handling of our loved ones, and then also burials. And markers of quality death and dying in the African perspective include decent burial, being able to say goodbye to your loved ones, and fulfilling the customary burial rituals. And all of these are no longer possible, and this is likely to result into complicated grief and bereavement outcomes. And then we have a challenge of declining donor funding, and so many palliative care services are closing down. And also at household level, we know that 70% of caregivers in Africa are women, and this work is unpaid for. And previously, women have been meeting in small groups. They learn together and pool resources and are able to engage in livelihoods. And then they can take care of the patients and also meet some of the financial requirements for care. But all of this is no longer possible because of the impact of the pandemic. And we are therefore emphasizing the need for universal healthcare coverage, which should also include palliative care. And innovations, we are now taking on e-learning. We are now engaging in risk communication to ensure that our patients and families are safe. And we are also responding positively to global health securities. We are using PPE and screening our patients to limit transmission of COVID-19 to fellow patients who may be coming into the health facilities. And we have a very high uptake for the use of digital health in the delivery of health services, in networking as healthcare providers, and also keeping our patients in contact with each other and also in contact with their healthcare providers. Thank you very much for your very kind attention.
Now my enormous pleasure to introduce our third and final speaker, Professor Irene Higginson. Irene.
Thank you very much, Richard. It's a real pleasure to be here and a challenge to follow two such wonderful speeches and interesting talks. I'm going to tell you a little bit about some work that we've been doing with a multinational study called the COVPAL study. And I'd like to, in a way, first introduce it by sharing my take-home messages from today, because in case the internet goes down or whatever, I'll start with what I want to tell you and then I'll tell you a bit more of the details. So what we found in the COVPAL study is, as you've seen from the two speakers before, palliative and hospice care responded actively. But I'm going to show you data that shows how it was often missed from the multinational pandemic responses, which limited what palliative care could do. In our survey, 81% of palliative care services have been caring for people with COVID-19 by mid-2020. And if we prepare for future COVID-19 surges, then I think we need better research. We need better integration, and this is urgent, especially for the charitably managed services. We need recognition, staffing, equipment, and access to some of the symptom medicines. We can probably expect that there will be increased pressure on community and hospital services with fewer admissions to inpatient units. That we know now that we can actually aid the symptoms, but we need to take care, particularly with advanced care planning and communication, and find ways to hang on to the individualized care that we want to offer. And we need to capture some of this learning for the future. I'd like to pay tribute to the many leaders of palliative care across the world in all sorts of different roles, both leading by providing care on the ground day to day with patients or by studying, and also pay tribute to the patients and families who've helped to promote the need for services, the many colleagues, the journal editors, the charities, and the funders, and many others who've supported this. So, does palliative care have a role in pandemics? We asked ourselves, and think that in 93 days only, COVID-19 changed from a mystery illness to a pandemic. Was palliative care in the international and national guidance? No, it wasn't. The World Health Organization and many governments put out multiple reports. The WHO put them out on prevention, intensive care, maternity, how to maintain services. People built hospitals, they built intensive care units, all necessary. Even as late as July 2020, the 11-point plan from the WHO on long-term care had nothing on palliative care. And so the action here was left mainly to palliative care community to raise the awareness of need and to search for solutions. And because we've got such a diverse and fantastically diverse audience, for me, palliative care is that type of care that puts the person and those important to them before their disease. And I've given you two quotes from Cicely here about how we must give everything we can to people that says you matter because you're you, and to enable every person to live up until the point that they die. So to live well before death, as well as supporting people who are at the end of life, and to help the family go on living after. And we know that palliative care aims to add quality to remaining life, and there's no evidence that it shortens life expectancy, and indeed we have very good data in many conditions that good palliative care can actually extend high quality life. Now, in South London, we were at the front of the wave of the UK pandemic in March, and we saw our cases early on in March, and you can see from the graphs here how very quickly the clinical load changed in the hospital to people with COVID. And in response, we launched work on education in particular pioneered by Ruth Ting and building on work by colleagues in Italy, sort of 15-minute brief teaching for healthcare professionals and students. We were able, as the principal outlined, to continue our existing education for students. And we launched a program of research trying to learn from earlier epidemics, to try and study how to manage the symptoms, to look at changes in practice, to review evidence and provide the best in care, to try and hear the voice of patients and families, to look at what we could do to support care homes. And we're running a project at the moment on supporting care homes and developing care home support in South London. And also we launched our multinational study. Now, bringing in the patient and family voice was critical because these were missing. And we had a great advantage because we'd already established an online patient and family platform for consultation. And in this, looking at what research we needed to do and what the issues were, we highlighted 4 main areas of concern that people who were affected by serious illness were worried about. One was in the area of reduced professional support. So delays in existing services, could they still get access to them? What sort of information was available? One was around fears of the reduced quality of care, worries about rationing, communication and how would people hear the care preferences? How would holistic care be maintained? A very important reflection on the needs of informal carers who had increased responsibility often, but fears around caring and risk of infection and introducing infection, and then isolation measures that turned carers from carers to visitors in many situations, which is a very difficult transition. And I'm pleased that people are beginning to recognize that we need to respond to this differently as we go forward. And then the challenges of loss, grief, and bereavement. And you can access this report here, but there's links from our website at the bottom, the Cicely Saunders website. So the COV-PAL study was aimed to try and really learn from what so many people were doing in palliative care and share that learning and see if we could quickly understand what people were doing and improve care. And we had many partners in this study, you can see across the UK, but also with the European Association of Palliative Care. And the study had 2 components. We surveyed palliative care and hospice services. That's what I'm going to talk to you about now. And we're in the middle at the moment of a study on symptoms and outcomes. In the survey, which is now closed, we had 458 responses, 277 from the UK, 85 from the rest of Europe, 95 from the rest of the world. And those of you who are quick at maths will realise that there's one there where we didn't have the country in the response and we couldn't work it out or get back to that. We had a very good mix across different settings, so home, hospital, care home, and we had a good mix of charitable and public management services. So as I mentioned, palliative and hospice services were very active in caring. 81% had cared for patients with suspected and confirmed COVID-19, and 77% of the services had had staff with suspected or confirmed COVID-19. And the first 3 papers on this work are out in preprint just the last 2 days. There's the link here, and when I go through each paper, I'll show it in detail, and I think my colleagues are tweeting this and it's on our website. I think it's important to recognise that people who are severely ill or dying from COVID are different. And we identified 3 main categories, and I think that our response needs to think about this differently in the future. So there are people who have some underlying health conditions and or multimorbidity, but they're not previously known to anyone in palliative care. And actually, that was the most common group of patients that palliative care services found themselves working with, people that they'd never known before, suddenly new groups of patients who had needs. There were also people who were already known to palliative care who got COVID. And remember that most palliative care services were also, or all palliative care services were continuing to support those people who were already in their care in a different way, as Steve and others have outlined. And then there was the people who'd been really very healthy, and now suddenly were no longer responding to any treatment and were dying from COVID. Now, one of the things that many people reported is that there was less activity for inpatient palliative care units. We can discuss why, but one of the possible reasons is because of the visiting restrictions, many people didn't want to go into an inpatient palliative care unit. And there was increased activity for home care and hospital teams. The other challenge for hospices, particularly charitable hospices, is that the support from volunteers considerably reduced, partly because volunteers were often needing to be shielding or staying safe themselves. And for many hospice and palliative care services, there were major financial concerns, with staff taking pay cuts, concerned for the viability of the services. And shortages were very common, especially of staff and personal protective equipment. So if we look at those by management type here, you can see that particularly personal protective equipment, PPE, was very severely short in the charitable sector, and this pattern is repeated across the world. As you can see in the next slide by world region, you can see that the PPE shortages were around 50%, even higher than Eve mentioned in her talk, for the UK and the rest of Europe. And interestingly, the shortages were similar in the number of services reporting them. When you dig into the detail, they seem to go on longer in the UK than the rest of Europe, in that people were still having them shortly before the survey and they hadn't got better. But actually, this was a common problem. And staff shortages were also a major concern, overall around 40%, and particularly affecting UK services. Medicine shortages also existed, and it's fair to say that most of the medicines needed were not high doses, and they're common medicines, but they were needed and they were being used elsewhere, so it became difficult for palliative care sometimes to access them for our patients. One of our partner teams, led by Fliss Murtagh and Andy Bradshaw, looked at the advanced care planning issues. And one of the things that they noticed is that during COVID, existing challenges to advanced care planning, particularly providing high quality and individualized advanced care planning, were exacerbated. There were specific challenges related to COVID, so it's a novel disease. There's issues about communication because of wearing masks, etc., workload and time pressures. And services adapted rapidly with local processes and structures, using technology, shifting resources. And I think there's implications of this. Again, this has come out just these last couple of days. The starting point to any discussion, and we need to be advocating this from palliative care, should always be the patient's values and priorities. There's a practical thing to improve sharing of information between services about wishes and keeping this up to date. And particularly because of the different groups that we see, parallel planning may be important. So planning if patients get better or if they don't. And we need to think about the future integration of this. And then we see the issue of innovations. Now, we've heard a lot about the technology innovations, and the team working on this data, Professor Catherine Walsh, Nancy Preston and Leslie Dunleavy, coined a phrase which I rather like as the frugal innovations that palliative care came up with. So we've heard a lot about remote walking and support, telephone and video calls, signposting people to web resources. The importance of a well-supported electronic patient record system is vital. And people moved around the services so they could provide 7-day a week service and 24/7 on call. They opened bereavement support to all families in the area. In some hospitals, because there were people who needed palliative care in hospitals, they actually created a new palliative care ward. Some inpatient hospice and hospice services developed gift or essential boxes for people, particularly those who are at home. Virtual programs were developed. So, for example, a virtual day therapy programs. A lot of services did much more linking and supporting into care homes and or developed toolkits for care homes. And a lot of people had to, this time, produce new guidance. So an international team led by Sabrina Bourgeois developed guidance for supportive and palliative care, which was translated in collaboration with the European Respiratory Journal and the European Lung Foundation into many different languages. And we developed, jointly working with colleagues in various places, simple self-help support for people so that they could self-manage their problems at home, particularly those who didn't want to go out, had fear of catching COVID and had problems such as severe breathlessness. And there was an awful lot of publications from the group focused on trying to support all people who needed palliative care. So early on in the pandemic, we got in touch with Italy to try and understand what was happening in Italy first. We reviewed the literature. We modeled what happened in terms of mortality and the shifting patterns of where people were cared for and where they died. We looked at the symptom management to try and understand how that would be better. Led by Richard Harding, there was work looking at advanced care planning in Jordan. There was work with my colleague James Beattie looking at support for people with heart failure. Other studies and analysis looking at uncertainty and how to respond to that in COVID-19. Anticipatory prescribing in the community with my colleagues in both Cambridge but also Rob George locally. And then Lynn Turner-Stokes did a lot of work leading how to consider the issues of rehabilitation. We took some lessons from HIV rehabilitation. We looked at how to produce guidance on how to take this forward and also to produce more guidance on palliative care, and most recently published in the British Medical Journal some further guidance on how to manage patients with COVID-19. A lot of this is contained in our triennial report. You can see the details of this here, and they're also in the announcement for today's chat that you can see. So back to my take-home messages. There are many leaders, and palliative care has shown enormous leadership in this story, and I'm terribly humbled by that. Palliative and hospice care responded actively, but I fear the evidence of the shortages, the comments that we got in the CovPal study, the extent that people had to struggle to get hold of things or get into the system is that it was largely missed from the multinational pandemic responses. I hope as we go forward we can rectify this. We're now, in 2014, the World Health Assembly announced that palliative care should be an integral part of all healthcare systems, and all countries signed up to that. And yet the this work and the COVID pandemic has shown the challenges that still exist in that. And in preparing for the future, we need to look at research, particularly the integration within healthcare systems, the recognition of palliative care and the access. Think about how we might use services with perhaps responding to the pressure on community and hospital services, how we take care about symptom management, advanced care planning, and capture the learning. And for that reason, the Cicely Saunders Institute is working on at the moment and will produce next month an action plan for better palliative care, which we hope will improve palliative care for many people with many different illnesses, not just COVID-19. It's important to recognise that we still need to support all the people who have all the illnesses that we used to support before, as well as this new group with COVID-19. So the action plan will be produced next month, trying to bring together both our own learning, but that from other teams across the world. And I'd like to end with the many colleagues in the Cicely Saunders Institute, to the patients and families who've been engaging with us in this journey, and to the many people who stepped forward to support this. Thank you.
I'd now like to turn back to our guest sites this afternoon and go first to Oxford.
Thank you. Hello to everyone from Oxford, and thank you very much for the opportunity to join you today on your anniversary. Thank you to 3 speakers for fantastic talks across the global palliative care world. May I go back to asking about how we have an opportunity to make palliative care visible immediately, because certainly in England, I see the same, as we begin to think about a second surge, see the same discussions about healthcare, but not about care of those who are going to die of this disease. Thank you.
If I could ask you each to give your brief responses so that we can get through the questions, that would be great. Thank you.
Shall I start? I'll be very brief. I think it's a wonderful question, and thank you. And I mean, in a way, this sort of event and the fact that we've put this work out will help do that. And it needs several actions, and lobbying is important, but also bringing in the patient and family voice is going to be important. And I think we need to join together for this. We need to help each other.
Really 2 issues. I think this is really important. One, the economic crisis has really put many palliative care services at risk. And so making the case to simply sustain palliative care services in the face of increased need has been very important. And so one important opportunity is just to make the case for palliative care to make sure that things don't get cut. I think the second, as you point out, and it has been highlighted interestingly in the lay press as well, with many stories about the fears of dying in hospitals and dying alone, and has really highlighted the need for palliative care and to help people make decisions about whether they even want to go to the hospital. So some of the most sort of dramatic and troubling scenes and stories have actually served as a stimulus for really talking about palliative care in a much more open and public way, and the recognition of its importance. And I completely agree with you. I think we have to continue to make that case.
Yes, my response resonates with what Steve suggests. Actually, when patients check in with severe to moderate COVID-19 and some never make it, people are worried and are increasingly recognizing the importance of palliative care. So this is a springboard for us to step up the advocacy and have it included in the universal healthcare coverage.
And now I'd like to move on to Belfast, please.
Okay, so hi, thank you very much. Those are really interesting talks. I suppose in Northern Ireland we got off quite lightly during the first wave of the pandemic compared with what we saw happening in London. But I think we're paying the price for that now, really, when we really are in much more challenging times in our hospital settings. And I suppose we've really seen the fall off of admissions to our inpatient unit. And I think, as you've said, Irene, both people don't want to come in because of visiting, and I suppose there's always a fear of COVID. And I suppose we're just wondering, do people have any suggestions of things that they have tried that worked? Our hospitals are getting to capacity with COVID, and I suppose we want to make best use of our inpatient beds, as well as we've obviously seen the increase in our community services, as we're seeing with yourselves. So any suggestions on how we can improve encouraging people to come in their hospices?
It's a really good question about, for people who really need to come in. Many of our patients are like yours. They don't want to come in. They're worried about getting COVID if they didn't have it, and they're worried about getting stuck in the hospital by themselves and not having their families with them. And so a lot of the work has really been clarifying goals of care and coming up with alternative plans. I think, Irene, what you highlighted just about managing shortness of breath at home, for example, and how would you manage breathlessness on your own has been really important. It's something that patients fear, and providing that sort of backup for many of our patients. It's been potentially enrolling in hospice. We've had to really think about how we provide 24/7 access to palliative care in a way that we hadn't before, in case things go badly for patients on weekends in the middle of the night, for example. So rather than figuring out how to bring them in, it's for us, it's been a lot of respecting how we can continue to care for patients in a way if they don't want to come into the hospital, and supporting that.
Briefly comment, if I may, but I'd agree with that. And I think you could think quite creatively. How could you support care homes to help look after people? There is a potential for hospices, and some hospices have done this, to sort of split the provision and have a COVID area and offer some step down for people who have got COVID over a longer period of time. They're not best suited in hospital, they're recovering slowly, they've got symptoms, they might do quite well in a hospice unit where you have the sort of therapies and other things, but also it's what you can offer virtually. And there are huge pressures on keeping people at home and huge pressures on the hospital services. So also you have uniquely skilled staff that are desperately needed in these other settings. So I would encourage you also to think about that.
Yes, it's about making community-based care safe, and also hospice or palliative care service, outpatient care safe. Ensure there is good PPE, people are screened, and then those who may have symptoms suggestive of COVID should be moved to a designated area so that other patients feel safe.
And so thank you. If I could move to Preston now, please, Andrew, if you'd like to ask your question.
Yeah, thank you. And again, 3 fantastic lectures, so thank you so much. Can I ask a question about telemedicine? As was described, we did the same up here, lots of virtual working, both primarily community, but also on our inpatient unit. And I think we've seen the benefits, and a lot of those positive experiences were described. But I just wondered, have you any experience of, I guess, negative outcomes from it in terms of patient and family experience, or possibly also the quality of the assessment, given the fact that, your examination is taken away from you?
So generally, it's been very positive. The physical exam is limited. I think we're getting more comfortable with asking patients to move their video around and, show me your legs and, show me the rash that you're talking about. And so we're getting more comfortable with that. Whereas at first, I think we were very nervous about doing that. So trying to do some of it. We've tried to be very thoughtful about what, just being clear about what you can assess by video. I think that's an area for research to really think about how to do more standardized assessments that way. There was something in the Q&A that I just want to highlight. A challenge is that sometimes when the visit ends, the telemedicine visit ends, for example, in the hospital with a patient in the ICU, the family is still pretty upset by what they've seen of their loved one and not being with them and not being able to hold their hand. And it does require some follow-up. It's not like we're done because our consultation is over, and really calling attention to whose job that will be, whether it's the navigator, whether it's for us, our clinical nurse specialist, sometimes our social worker or chaplain, to really stay connected with the family and to help them sort of process it. And I think, and on the flip side, that's been true for some of our staff as well, who have found the experience of families being separated from their loved ones, for example, in the intensive care unit, very distressing, and just adding to the stress of caring for patients. You're already in PPE, your patient is very sick, and now they're dying alone, and then witnessing that has been very stressful. And so attending to the psychosocial needs of staff as well as families.
Thank you very much, Andrew, for your question and for joining us from Preston. And now I'd like to move back to Cork, please.
Okay, thank you. There are some wonderful lectures and lots of learnings for us. Our question here again is in relation to tele-palliative health. We've done some qualitative work here in Marymount Hospice, and it's become very clear that a unique skill set is actually required to deliver tele-palliative medicine. There are kind of unique and discrete and different cognitive, emotional, physical and ergonomic demands, I think, that this places. And I guess I'm just wondering, from an occupational health perspective, what measures either have you put in place or you see the need for?
Thank you so much for bringing that up. That's really important for clinicians spending an entire day sometimes doing telemedicine and attending to the ergonomics. UCSF has an ergonomics office, and we actually had a session with one of our kind of ergonomics experts to try and highlight for the team how to be as safe as possible with the ergonomic setup. You know, that, the lighting, the privacy issues. I mean, there really is I agree with you. I think there really is a skill set to doing this that, I'll be honest, before the pandemic, we really didn't attend to. It was like, wow, this is pretty terrific. Let's just do this. It really works. And now that it's all this way, we're really attending to it. And I think, to your point, how do we teach our students who are coming up now? This is a new skill that they need to have. And I think the way to do this is really to study it, to really look at these issues and to really study what is the nature of the conversation, what is happening in real time. I mean, the beauty is you can record these very easily because they're on video, but beginning to assess this and really understanding from patients and families and the clinicians about what works well and what's gained and what's lost in this.
I just agree, and I think that we need to study the patient's response to this. And I think there's two elements: the sort of staff response and how they feel and how we train staff to do it, but also how patients and families find it from their side. And I think that does require some evaluation. In the CovPal study, our next step is to do some case studies. So we will be looking at some aspects of that, but I think that there's a huge opportunity to learn from how we've done these things here.
We are grateful that we had started evaluating the use of digital health earlier. So it was an opportunity for us to respond positively to the global health security threat. Some of this work has been led by Professor Harding, and then some of the work has been led by the African Palliative Care Association and colleagues from Leeds University. So we had done some groundwork prior to the pandemic.
Thank you. May I, Richard, may I just one other comment? I think one thing that we've really been concerned about in the use of telemedicine, I touched on it briefly, but is just to ensure access. Our concern is that in the use of technology, that you further exacerbate disparities in access to care. And we have seen from some of our colleagues at safety net hospitals, for example, San Francisco General, that not all patients have access either to internet or to devices. And there are even some concerns about, downloading apps that may, quote, monitor you. And I think there's a lot more to be understood and to ensure that access is at least maintained and perhaps even expanded through the use of these technologies and not further restricted.
And now to Massimo in Italy, please.
Hello. Thank you to the speakers. Really a very interesting speech. I think in this, well, I want to be optimistic in the definition. This rather complicated here. This event and the three speeches, one of the best things I ever had during this year. And I think this is one of the best events promoted by Cicely Saunders. So first of all, is my personal congratulations. The question is in line with this comment because there is at least we are trying to find something positive in what is happening. So my question, well, the last slide from Irene's presentation was about what do we take home for dealing with this epidemic. But my question is larger, if it is possible. What would you think to take home of positive, not from this epidemic, from the normal palliative care at the end of epidemic? Can you find something positive? Because this epidemic forced us to change everything. So I think just for a matter of probability, some of these changes are positive and not negative. So what do you think about that? Probably the first speaker is, it's easier for the first speaker to answer. Thank you very much anyway.
You know, it's a great question. It's actually something that we looked at as a division. One of our divisional meetings was really trying to look at sort of where's the silver lining in this very, very difficult cloud, as you point out, and what have we learned. And you know, one thing we've learned is the importance of palliative care. And I think, Irene, you mentioned that many of the patients that were being seen had not been to palliative care before, but had sort of a series of chronic illnesses, none of which brought them to palliative care. And yet suddenly there was this need for palliative care often on their admission to the hospital, and they were just at higher risk. So I do see that there has been a lot more discussion, particularly early in the pandemic when there were a lot of surges just about palliative care, and recognizing that alongside the ICU, palliative care was very prominent in discussions about the types of care that people needed and the role of palliative care. So I think that's one positive that we can take away. And yeah, I think I shared the positives about telemedicine. I know for us, there's no going back, but I think the team would like to be close together. But I think our patients, they by and large don't want to come in anymore. And I think that the opportunity here really, you know, we think of many parts of the world as being rural, but California is a very rural place as well, although we think of it as very urban. But we really see this as an opportunity to bring palliative care to settings that are, in fact, where there is no access now. So to nursing homes, I think that was really important, long-term acute care settings, even small hospitals and clinics dispersed across California to really use this technology to increase access you know, around our country in the U.S. certainly, and potentially around the world, where we could help each other.
Shall I go? Massimo, first of all, thank you for your very kind comments at the beginning. That's really lovely, and then and heartfelt. So I think that there are a number of positives. The first is that it's brought back into palliative care innovation, because people have been innovating very quickly and have done amazing things. And I think it has also brought back into palliative care a collegiateness, and it has brought back into healthcare, medicine and nursing, an awareness that people do get very sick, and many more people have had to deal with that and have had contact from palliative care. And I think that those things are all very positive. I think that we have found new ways to do education. In fact, your own group taught us something with this, because you said, well, you can't give them long education. We go on the wards, we do 15 minutes because that's all they've got time for. But they come to that in a way that they wouldn't have before. So I think we have an opportunity for engagement here, which is great. Telemedicine we've heard about. I think that the other thing for me is also that I think we have a new model of doing research as well as a new way of doing education, because I think that we have across clinical services, people have recognized and have felt that research is important, because all of the knowledge needed to be generated anew. And suddenly they had none, and they couldn't go to a dinner somewhere and be told by blogs what to do, because you couldn't go to a dinner anyway, and blogs didn't know anyway. So people had to study and find out, and actually that created a new dialogue. And I just hope we can hang on to that. I'm not sure we can, but I hope we can. So I think those are the pearls to be taken forward and to be held on to. All of these innovations that people have done, the palliative care has opened its doors and has done amazing things. And for me, one of the most positive moments in the pandemic, I'll be honest, has been attending Hospice UK ECHO meetings every couple of weeks and hearing what hospices have been innovating. And in a way, that's how I wanted to do the CovPal study.
The takeaways, first of all, one, in Africa, now we've learned to take global health security seriously, and that it should be integrated within palliative care health systems. And then it's been a great opportunity to collaborate with other specialties and to attend webinars and also tap into other financial and technical resources from other specialties. It's been an opportunity to learn and conduct research to answer practical challenging problems that palliative care was facing, and also to learn to take up technology for learning, for research, and for patient care. And we've learned to start investing early in innovations so that in case of the threat, we have something to scale up as opposed to starting from scratch.
Thank you, Eve. Thank you so much. Now, I'm aware of time. We're closing soon, but I'd like to lastly move to Dublin.
Thank you to all of you for the very interesting presentation. I'm here with colleagues from Our Lady's Hospice and Care Services, and they just asked me to reflect that they are building into their evaluation, building in an evaluation of how patients are managing their virtual assessments. They're building that into the process as they go. But the question that we wanted to ask is, have any of you experience of utilising telemedicine to deliver shared care in nursing homes between GPs and palliative care teams, and that the GPs and palliative care teams might be in different locations?
We haven't done it in that setting, but I think it's a really important question and very interesting to think about how telemedicine can be used to bring different clinicians to the bedside for patients. So I think it's a wonderful innovation. We have used it to be able to bring specialists into a visit with a patient, sometimes in the outpatient setting, more commonly in the inpatient setting. For example, the oncologist who might be at a different site for patients in the hospital receiving palliative care. But great idea.
I believe that, and I don't know if he's on the call or not, but I believe that Max Watson in Hospice UK is actually working on this particularly. And in a way, it's how the Hospice UK ECHO programs got set up. And so that would be worth contacting. And if Max is on the call, perhaps he can put it in as a question into the Q&A and you can connect with him. But otherwise, I would suggest contacting him via Hospice UK.
Thank you. Eve?
We've not tried that in palliative care, but it's happening in other specialties. So probably we have an opportunity to learn from our seniors.
Thank you. Thank you to Karen for our question from Dublin. In the chat, you'll notice there's been a huge amount of questions generated on place of care and mHealth, starting with what CovPal told us about shifts in place of care, Steve's innovation, Eve's work. There's one thing that's been coming through consistently, which is, has any of this work been evaluated in mHealth, and have patient-reported outcomes been measured in mHealth? Now, we're out of time, but Eve, you've just published work on this. Would you like to share a quick kind of summary of some major findings of what mHealth has done in Africa and India on the WHO project? What are the main findings from that?
Yes, we've piloted such a model in Uganda, Zimbabwe, and India, and we use community healthcare, community volunteers, and also informal family caregivers to collect data on palliative care outcomes using simple digital devices. And it was feasible for them to tell us how patients were doing on a daily basis. And our healthcare providers were able to use dashboards and look at the person-centered outcomes data and tailor the care to patient needs. The patients liked the experience. The technology was very easy for the users, and it was also cheap and affordable. So it is a feasible model for resource limited settings.
Thank you so much, Eve. And I think that paper's about to come out in JPSM. So thank you for the quick summary of that. So thank you to our three speakers, to our wonderful audience. And now it's my great pleasure to hand on to John McGrath, the Chair of the Board of Trustees of Cicely Saunders International, for some closing remarks. Thank you, John.
Good morning, good afternoon, good evening to you all, wherever you may be around the world, and welcome to this interesting lecture. I think the format of having three different views of this pandemic has been very, very insightful. And I'd like to thank the speakers for conveying the sort of things that have been going on in this incredibly complicated pandemic. So that was really wonderful. And also to the people who raised the questions. I was going to lead on and talk about what are the opportunities to make palliative care more visible. But in fact, the person from Oxford did raise that question, but I would only emphasize that this is an opportunity, but it is also a risk because there's an awful lot of noise on 24-hour media, which is talking about all sorts of different things. And we've just got to find a way to bring through how important it has been in a time when people have been dying without their families and friends. And that is a very unique and terrible experience. So anything which we can all do to achieve that would be fantastic. I think the other thing is that there must be a lot of learnings that we will find from what has been going on in this last 6 months. And over the coming years, we've got to bring around change to recognize those. I mean, we have real issues in the UK, for example, where hospitals and social care aren't integrated, don't work together. Care homes had a terrible time for very many reasons, as has been mentioned. And so let's first of all learn what happened and what we can do about it, and then make those changes. I think as this is quite a diverse audience, I ought to just explain very briefly the difference between the Institute and Cicely Saunders International. Very simply, Cicely Saunders Institute is the Department of Palliative Care headed by Professor Higginson, and is part of King's College London. Cicely Saunders International is an independent charity set up by Dame Cicely back in 2001-2002, which I am the chairman of. And those are the distinctions. And our task is to raise funds to support the Institute in carrying out high quality research, evidence-based, to understand how we can improve the life of people in their latter part of that life, either in hospice or home or in hospitals. And that's what we've been doing for quite a few years now, and which we will continue to do in the future. Now, Irene has mentioned that she is developing an action plan, which will be available next month, and that will be available on her website. And also, you've heard a couple of times now the triennial report, which is a very important document which lays out in quite some detail what the Institute have done over the last 3 years, and I think is a really interesting and informative document, and also is available on both on the Institute's website, and there's a link on the charity website to take you to that. Now, I've got a number of thank yous. The first one is to Professor Ed Burns. Firstly, thank him very much for his introductory comments. And secondly, to recognise the fantastic support we have received from him and his leadership over the years that he has been principal. And I think finally to say that the Queen honoured him very recently with a knighthood for his significant contributions to education. So Ed, many congratulations and thank you for all your support. My next thank you is to Sir Robert Leckler, who has already stepped down as Vice Provost, who has been a huge supporter of us for probably at least 15 years. And we really appreciate what he's done. I know he's involved more loosely with the university, but he will no longer be with us in the normal way. Next, I'd just like to mention the Garfield Weston Foundation, who very generously funded the technology which enabled this to happen today. And they have been consistent funders of us, and may that long continue. We have recently funded or had funded a new chair in palliative care at the Institute, and that has been funded by Kirby Lang, by the family of the Hospice Education Institute based in New England. Sadly, Michael Gillespie died a few years ago, but his family have contributed towards this chair. And finally, Atlantic Philanthropists, who have also supported us and have supported us with the Breathlessness campaign and other projects over the years. So a huge thank you to them. This is a chair of palliative care in perpetuity. So that is to us very, very important. Other funders what I'd like to identify are the Dunhill Medical Trust, Marie Curie, and also Sir Halley Stewart, but there are many others as well. Finally, is the Institute itself. Myself and the trustees have been really quite amazed by the response we've had from all the people in the Institute who suddenly had to work from home, but all sort of developed an incredible spirit of can-do and doing things much more, in some ways, much more rapidly and effectively than would be normal, and who were able to get peer-reviewed papers much more quickly and even get the papers into journals. So the whole system seemed to react positively to the pandemic. So a huge thank you to them. But I would like to identify separately the clinical team who all of a sudden in late March were taken from their jobs to the front line where the battle really was. They're quite young people in many cases who had to take on tremendous responsibilities. And I really think they probably haven't had the credit they deserve. So you've got it today. And really, thank you so much. Finally, thank you so much, Richard, for chairing this very effectively. Thank you all for viewing this today, and hope to see you next year.